And it's wonderful to be here and hear all of these great stories. And I'm really looking forward to more engagement with all of you. As Eddie so kindly mentioned, I am the founder and executive director of the Global Foundation for Children with Hearing Loss. I have also worn hearing technology myself since I was 11 months old. And I benefited from hearing technology and habilitation services when as a baby to be able to develop listening and spoken language. So this topic is really close to my heart, and I'm really pleased to have this chance today to talk about addressing habilitation needs. Next slide. So I think we all here are very familiar with this continuum of care, as we call it, that's necessary for young children specifically. And today I am going to be focusing on babies and young children in order for them to benefit from hearing technology. And so just quickly, we start with the early identification of hearing loss through screening program. It's necessary for the family to have counseling and appropriate support. And then, of course, the hearing technology, hearing aids, and then cochlear implant. And the last step is habilitation. And I think that we all have experienced gaps in all four of these elements, and in particular with the habilitation component. Next slide. So hearing screening programs have really reduced the age of identification in children, which is fantastic, as it enables us to have a chance to help these children get on track for success at earlier ages. But with that earlier identification comes a unique challenge, because many professionals in many countries are not trained to work with very young children and babies after they've been identified with hearing loss. And I would like to mention that habilitation is different from rehabilitation. So rehabilitation focuses on improving communication skills in those who already have spoken language. What we're talking about here is habilitation, which includes auditory verbal therapy, which helps babies and young children with hearing technology develop audition speech and language during their formative years. And this outcome can only happen in the first few years of life. And I think you all know this, but I just wanted to be clear about why I'm talking about habilitation. We know that there's a limited number of professionals, especially in low-resource countries, with the expertise to coach families and support children who are babies and very, very young children with cochlear implants and hearing aids. And there's a lack of family understanding about the importance of auditory verbal therapy and their role in it. And because the time horizon can be long, if families are not counseled well, they can become discouraged and feel like it's not working, when in fact it is. It's a process. We know that while it's great that there are cochlear implant packages that children can receive that include auditory verbal therapy in those packages, usually the time scale is just for 1 year, and that's just not enough, especially in children who, well, for all children, but for children who are implanted at age 3 or 4, they will definitely need more than a year of therapy. And so what ends up happening is after that year is up, families are faced now with this high cost of supporting ongoing therapy. And if they haven't been counseled well, and the importance of that is often put aside, or they just simply can't afford it. And then, of course, the children are negatively affected. So family support and the habilitation components are really key, just as important as the hearing technology itself for positive outcomes. Next slide. So I wanted to provide one example of how the Global Foundation is helping to address some of these challenges around habilitation in low-resource countries. So in Nepal, there's only about 50 speech therapists in the entire country, which of course does not even begin to meet the need, particularly for regions outside of the capital of Kathmandu. And the speech therapists in Nepal are not necessarily trained to work with babies and young children. Universal newborn hearing screening is not a reality there. So even though there are places that are starting to do screening, it still is not the norm. So working with a baby is very different from trying to do speech therapy with an older child or an adult. So the WHO, has encouraged task shifting as a strategy to improve access to care. And task shifting is the process of redistributing more basic tasks to less specialized workers, such as community health workers, nurses, or technicians. So among other things that we've been doing in Nepal, my organization, the Global Foundation for Children with Hearing Loss, has been teaching a training curriculum in auditory vocal therapy to both professionals and to community health workers in the country. Nepal has a lot more community health workers than they do professionals. I mentioned there's only about 50 speech therapists in the country, whereas they have a tremendous network of community health workers. So by leveraging that great network, who are also not just concentrated in the capital or the major cities, but also throughout in the communities, we can really take advantage of this network to make sure that there's more services available to children with hearing loss. So our model is such that we provide in-country training workshops that teach the curriculum that we have prepared in auditory verbal therapy. Our team is certified listening and spoken language specialists, mostly from the United States, but Canada and other countries as well. And so over time, we have developed this curriculum, and then we travel to the countries to teach it. But it's not in 1 or 2 days. We invest years in the countries trying to lay a foundation of understanding and expertise. And those we train are then prepared to train other people in the country to make the benefits exponential and sustainable. We provide the hands-on practice as well as theoretical lectures. And this is really key because, as you know, you can hear all you want about a topic, but until you actually apply it, it's not really going to be a skill set. So that's why we really focus on the hands-on practice. We use interpreters to help with smooth communication. And the participants in our programs work with us to customize our curriculum to really meet the needs of the people and the culture in which they live, and also address the nuances. So Nepali language is different from English language in many ways. So we can't just teach how we do things in English. We have to take into account how things are done in Nepal. So these are just a few of the ways that we're able to provide value, in addition to family programs to help try to raise awareness for the importance of auditory verbal therapy amongst families who currently don't have a lot of information about this. So next slide. Oh shoot, can you go back? I'm sorry, you skipped over one slide. Okay, that's fine. So what we have done in Nepal with the training is that the implementation of this training is done in a way that those we have trained are aligned with speech therapists in Nepal. So we also are supporting screening efforts and referral to appropriate places for hearing technology. But aside from that, the people that we have trained can be a resource for families after they get their therapy plan from a professional. So these community health workers, of course, will never be full-on therapists, but they can play a very key role in supporting families when they go back home and helping to make progress with their therapy plan, because they understand the strategies, they understand different activities that can help the families. So it just provides families with extra support at home, and they don't have to travel all the way to Kathmandu and pay high sums of money in order to help their children progress. And we this program could eventually include teletherapy. I've seen several people have been mentioning that. Definitely a lot of benefits of teletherapy. But one of the things we have learned over time is that in countries where they don't have therapy or is not widely available, it's important to provide that in-country training first, because otherwise it's difficult for them to understand how to learn online. Is very different from learning in person. So I think there's a role for both methods in trying to address some of these gaps. So we can move to that last slide. Yeah. So the last slide, I just wanted to sum up, because we're all gathered here to talk about these challenges, try to talk about different solutions, what all of us have been doing at different places to try to address some of these gaps in habilitation. And I just hope that we together as a group can carry this forward and take advantage of CIICA's tremendous network to help each other advocate and make sure that children get everything they need, not just the technology, but everything around the technology. Thank you.